Welcome back to a Pediatric Dentist channel Tiny Tit Talks. If you are new to this channel, subscribe the channel, and for details of this channel visit the bio section, or you can also check out my previous videos. We are back with non-pharmacological behavior management techniques part 2. So today we will cover tell show do technique, desensitization and modeling. So start with the tell show do. It was given by Adelson in 1959. Tell show do is the classic model for communicating with children and favorably conditioning them to the dental experiences in which the dentist tells the child what is going to be done in words the child can understand. Second, the dentist demonstrates the child exactly how the procedure will be conducted, and finally the practitioner performs the procedure exactly as it was described and demonstrated. The objectives are first to teach the patient aspects of dental visits and to familiarize him with the dental setting to shape patient's response to various procedures. For this, the core framework is needed, which is the triple component approach. The first component is tell, the verbal explanation. Explain the procedure in age appropriate, non threatening language. Avoid scary words. For example, use sleepy juice instead of injection and whistling toothbrush for the drill. Explain before, during, and after each specific step. The dentist voice should be soft but firm and confident. Honesty is critical. If a step will involve pressure or pinch, the child must be informed to prevent a breach of trust. Show is the second component, the sensory demonstration. Allow the child to experience the procedure through their senses, sight, sound, touch, smell, in a controlled environment. So, first, show the mirror or suction tip, run the handpiece so they hear the whistle, and use a prophylaxis cup to spin on the child's fingernail so they feel the vibration. Never show sharp or fear inducing instruments like syringes. These should be brought from behind the child's field of vision. Then, third component is do, the execution. Perform the task exactly as it was demonstrated and described. Rule of consistency. Any deviation from show phase can lead to immediate anxiety and loss of cooperation. Do not proceed until the child demonstrates an understanding and a level of comfort with the show phase. Then there are some modern alternative and variations of tell show do. So as a pediatric dentistry evolves, tell show do has been modified to better suit different cognitive levels and modern learning styles. So ask, tell, ask. The dentist asks about the child's feeling knowledge, tells them about the procedure, and then ask again to confirm the understanding. This ensures a two-way dialogue. Then tell, play, do. This incorporates play therapy. The child might perform the procedure on a toy or a doll first, and this is highly effective for younger children who are 3 to 5 year old, who learn best through imitation. And enhanced tell show do using digital aids such as showing the child a 3D animation of the procedure on a tablet before start. Recent research has focused on integration technology to make the show phase more immersive and less threatening. So first is virtual reality and augmented reality. Virtual reality is completely animated space, and augmented reality are basically a computer generated image which is animation on a user's view of real world. So there is a partial animation in the augmented reality. So dentists are now using VR headset to provide virtual tell show do. Instead of just looking at an instrument, the child enters a gamified version of the dental office where they interact with the virtual tools. These serve as both a distraction and a preparation tool. Then dental operating microscope. Use a live feed from a microscope allows a child to see what is happening on a monitor. This transparency often reduces anxiety because the child feels in the loop regarding the treatment. Then video modeling. Studies have shown that watching a video of peer another child successfully undergoing a dental procedure using tell show do is often more effective than the dentist explaining it alone. This uses social learning theory to build confidence. And then there are some research related to tell show do. First research is for the efficacy of tell show do play. They concluded that incorporating a play component component where the child acts as a dentist on a model significantly reduces psychological stress, and the study found a lower mean increase in heart rate compared to the traditional Telshodo, indicating superior anxiety management. Then the meta-analysis of Telshodo effectiveness. So meta-analysis of 12 clinical trials confirmed that Telshodo significantly reduced dental anxiety by 0.54 units compared to no intervention. It remains the most effective foundational non-pharmacological technique across diverse pediatric population. Then Telshodo versus virtual reality. So while Telshodo is effective, the integration of virtual reality as an adjunct during the show phase offered superior pain and anxiety reduction. The study concluded that VR plus Telshodo is significantly more effective than Telshodo alone for invasive procedures like pulpotomies. Telshodo versus smartphone game apps. Comparing Telshodo Play, and smartphone games, the Telshodo Play technique was the most effective in reducing dental fears. Standard Telshodo was found to be baseline. However, children engaged in a play or a digital games showed higher oxygen saturation level and lower pulse rate during the treatment. Then desensitization. Desensitization is a psychological behavioral therapy designed to reduce or eliminate the exaggerated response to a fearful stimulus. Originally popularized by Joseph Wolpe in 1950s, it has become a fundamental strategy in pediatric dentistry to manage phobic children and those with the pre-established fears. So the core mechanism is systemic desensitization. This technique based on the principle of reciprocal inhibition, means the idea that one cannot be both anxious and relaxed at the same time. So by pairing a fear inducing stimulus with the state of deep relaxation, the link between the stimulus and anxiety response is eventually solved. So first we have to understand the three pillar of Wolf's technique. So first is relaxation training. The patient is taught deep muscle relaxation or guided visual imagery, example imaging a happy place. Then hierarchy of fears. A list of dental stimulus is created ranked from least to most provocating. Then graduated exposure. So while in a relaxed state, the patient is exposed to the hierarchy starting at the bottom. They only move to the next level once the current situation no longer triggers anxiety. The dental anxiety hierarchy. So, according to Howitt and Stryker, the hierarchy of anxiety evoking stimuli for a child typically follows these orders. Lowest anxiety is generated in prophylaxis, then hand instrument, then rubber dam, dental drill, dental environment, and the highest anxiety generated by local anesthetic injections. Then preventive desensitization. While traditional desensitization treats an existing phobia, preventive desensitization aims to prevent a phobia from ever forming. The pre-sensitization reality. Even if a child has never visited a dentist, they may be pre-sensitized by negative depictions in media, scary stories from siblings, or previous painful medical experiences like vaccinations. So the approach is this involve a graded introduction to the dental office using easy procedures for examples like brushing instructions and fluoride before attempting hard procedures like fillings or extractions. The Telshodo technique is clinical vehicle for preventive desensitization. Then modern advancement and recent researches. So desensitization has evolved significantly with the integration of cognitive behavioral therapy and digital technologies. Digital desensitization and VR. Recent studies shows that virtual reality desensitization allows children to navigate a digital dental office before the actual appointment, and this provides a safe versions of the hierarchy where the child can turn off the scary stimulus if they feel overwhelmed. Then desensitization for neurodivergent patients. So a major focus in recent literature is the use of visual pedagogy to desensitize children with the autism spectrum disorder, and these children often require a more granular hierarchy focused on sensory triggers. Then there are some conclusive or research papers. So first is CBT based desensitization. desensitization. So, a study concluded that the integration of the cognitive behavioral therapy style positive self talk into the desensitization process reduced the dental avoidance behavior in 85% of the phobic adolescents compared to the traditional tell show do alone. Then, parental influence on the sensitization. So, research highlighted that vicarious sensitization, watching a parent's fear, is the number one predictor of a child's dental phobia. Desensitizing the parent is now considered a prerequisite for the child's success. Then, smartphone apps for desensitization. Randomized trial found that the children who use dental adventure games, which mimic the dental hierarchy, for 1 week prior to the visits had significantly lower salivary cortisol levels during the actual procedure. Sensory adapted environment. So, recent papers suggest that sensory adapted dental environment using weighted blankets and dimmed light act as a powerful inhibitor of anxiety, makes desensitization faster and more effective. Effectiveness in autism spectrum disordered patients. So, a longitudinal study found that a 4-visit desensitization protocol for ASD patients increased successful completion of dental cleanings from 30 to 75% without the need for sedation. Then, modeling. Modeling is highly effective non-pharmacological behavior management technique based on Albert Bandur's social learning theory. You can check out the social learning theory, which is already on the channel. It posits that a child can acquire a new behavior and reduce anxiety simply by observing a model who might be a peer, sibling, or parent successfully navigating a dental procedure. The psychological foundation, which is based on social learning theory. So, modeling works through the 4 cognitive process. First is attention. The child must focus on the model's behavior. Then, retention. The child must remember the steps observed. Then, reproduction. The child must have physical ability to mimic the behavior. And motivation. The child must see a reason to copy a behavior, usually through seeing the model get a reward or a praise. Types of model. Mastery model. A child who is perfectly calm and enjoys the treatment. This is best for children with the low to moderate anxiety. Coping model. A child who initially shows some hesitations or mild fear but use coping mechanisms like deep breathing to finish the procedure. Research often shows that anxious children relate better to coping models because the model's experience mirrors their own. Then, implementation. Live versus audiovisual modeling. So, live modeling, siblings or peer having an older cooperative sibling go first is the most common form. The patient watches from a distance or at the chair side. Then, parent, as noted by Kyle in 2009, mothers are often highly effective models, though the child's age and the parent's own anxiety levels are critical factors. Then, audiovisual filmed modeling, video presentation. Children watch 10 to 12-minute video of a peer undergoing the exact procedure they are about to have. The advantage is the dentist can control the narrative of the video, ensuring the model demonstrates the exact desired behavior and receive a positive reward at the end. Some recent advances. So, contemporary research has moved beyond simple video to interactive and digital version of modeling. So, peer versus expert modeling. So, a study comparing peer modeling, which is child model, versus expert, which is dentist demonstrating, found the peer model lead a 20% higher cooperation rate in the children aged 4 to 7. Then, children are more likely to internalize behavior from those they perceive as a like them. Then, video modeling via social media. So, research found that short form video modeling, like 60-second TikTok style clips sent to parents via WhatsApp 24 hours before the appointment, was more effective than showing a longer video in the office. This pre visit priming allows the child to process the behavior in a safe home environment. Then, modeling in neurodivergent children. For children with the autism spectrum disorder, modeling is most effective when combined with the social stories. Observing a child while simultaneously seeing a visual schedule of the steps improved successful chair sitting by 65%. Then, sibling modeling and the physiological sync. Using a live sibling model was found to synchronize the heart rates of the model and the observer. If the sibling remained calm, the patient's heart rate stayed significantly lower compared to the children who did not observe a sibling. Then, VR-based modeling. So, virtual reality modeling, where the child watches a 3D avatar of themselves undergoing treatment, was shown to be more effective than watching a stranger. This self-modeling creates a powerful psychological blueprint for the success. These research papers, references, and conclusion I show for specially pediatric dentistry residents who have to mention some research related to topics in exams. I will give you all the references at the end of the non-pharmacological behavior management techniques. If you want this PDF or any other PDF, like, share, subscribe the channel. New videos on Sunday, and we are uploading topic of the week shorts which are very important for your revision and competitive exams. Thank you.